Okay, let's talk about acute heart failure. The name itself sounds pretty serious, right? And, well, it absolutely is. We're talking about a life-threatening emergency where the heart just suddenly can't keep up. It can't pump enough blood for what the body needs. So what's really going on here? Who's most at risk? And maybe most importantly, how do doctors even manage it? We're going to break it all down in this explainer. So here's our game plan. First, we're going to get a solid handle on what this emergency actually is. Then we'll dive into who it affects most and why it happens. After that, we'll cover the really critical warning signs you need to know. And to wrap it all up, we'll look at the medical playbook for tackling this crisis. All right, section 1. Let's kick things off with the big question. What exactly is acute heart failure, and what are the two main ways it shows up? So, at its very core, acute heart failure, let's just call it AHF, is a sudden, really severe medical event. I think the two words you absolutely have to remember here are sudden and worsening. This isn't some slow, gradual decline. No, this is a full-blown crisis that pops up fast and demands immediate, urgent medical attention. Now, this is super important. AHF isn't just one thing. It can show up in two totally different ways. The first is called de-novo AHF. Think of it as brand new heart failure. It just appears, seemingly out of nowhere, and someone who's never had it before. But what's actually much more common, we're talking 2/3 to 3/4 of the time, is decompensated AHF. This is when someone who already has a chronic heart condition suddenly gets a whole lot worse, really fast. Okay, so now we know what it is. Let's move on to the next big question. Who is most at risk? Let's take a look at the numbers. All right, 200. What does that number even mean? Well, it's the incidence per 100,000 person years. Let's try to make that real. Imagine a city with 1 million people. With this rate, you'd expect to see about 2,000 cases of acute heart failure pop up in that city every single year. So it's definitely not a rare event. And if we zoom in on the profile of a typical patient, what do we see? Well, age is a huge factor. The risk just climbs and climbs, really peaking for folks who are over 70. But here's something that might be a little surprising. Unlike a lot of other heart issues, AHF doesn't really play favorites. It hits men and women at pretty much the same rate, a 1-to-1 ratio. Now, to really get a feel for how common this is, let's put it side by side with another serious medical emergency. Take a look at an acute flare-up of COPD. As you can see, that's actually 7.5 times more common than AHF. It just goes to show you, while AHF is incredibly serious, it helps to kind of place it on the map of public health challenges. Okay, so we've covered the what and the who. Now it's time to get into the why. We're going to look at the heart's big problem here. It's a pumping problem, really, and explore what's actually going wrong under the hood. So, the million-dollar question, what is actually happening inside the body to trigger this whole thing? Well, it's not one single answer. It really depends on which of those two paths we talked about earlier. Is this a brand new problem, or is it a flare-up of something that was already there? All right, let's talk about that de novo or brand new heart failure. In these cases, the trigger is usually some kind of direct assault on the heart muscle. It could be a sudden lack of blood flow, that's what doctors call ischemia, or maybe a virus that's decided to attack the heart. It could even be toxins or a valve that suddenly stops working right. It's a direct hit. But remember, the more common scenario is when a pre-existing condition gets way worse. In that case, you can think of it like the final straw that breaks the camel's back. The heart is already strained, it's already working overtime, and then something pushes it over the edge. What kind of something? Well, it could be a heart attack, a crazy spike in blood pressure, a sudden arrhythmia, or a heart valve problem that just got worse. Okay, so that covers the why. Now, let's get into what might be the most practical part of this whole explainer. How do you spot the warning signs? We're going to look at this from two angles: what a person actually feels, and then what a doctor observes to make the call. You know, when it comes to figuring this out, there are really two pieces to the puzzle. On one side, you have the symptoms. That's what the person is feeling. Things like being incredibly breathless, not being able to exercise at all, swelling, just being wiped out. On the other side, you have the signs. That's what a doctor can actually see and measure. We're talking about a bluish tint to the skin, a super fast heart rate, maybe even hearing crackles in the lungs. It's the combination of both that paints the full picture. Okay, get ready for a fact that might actually surprise you. You hear heart failure and you probably think the pump is weak, so low blood pressure, right? Well, nope. In over 90% of AHF cases, the patient's blood pressure is totally normal or even high. That's a huge counterintuitive clue that doctors really have to pay attention to. So, to be absolutely sure, doctors have a pretty standard diagnostic playbook. Think of it like a step-by-step investigation. First up, blood tests to check for things like infection or anemia. Step 2, a chest x-ray, which is great for spotting fluid buildup and checking the heart size. Then they'll often do an echocardiogram. That's basically an ultrasound for the heart to see if there are any structural problems. And finally, there's a key blood test for something called B-type natriuretic peptide. If those levels are high, it's a really strong sign the heart muscle is in trouble. All right, the diagnosis is confirmed. Now the clock is really ticking. So what's the plan? Let's take a look at how doctors manage this emergency, from the first things they do for every patient all the way up to the most advanced treatments. Okay, for pretty much every patient, the first priorities are the same. Take some of the strain off the heart and make it easier to breathe. The number one tool for this is IV loop diuretics. These are powerful drugs that help the body get rid of all that excess fluid fast. They'll also give oxygen to make sure blood saturation stays in a healthy range. And sometimes they might use vasodilators to help open up the blood vessels. But that's not a routine thing. It's safe for specific cases, like really high blood pressure. Now here's an interesting point that shows how medicine evolves. There's a direct recommendation from NICE that says, do not routinely offer opiates to people with acute heart failure. You know, you might think something like morphine would help calm a patient down, and it used to be pretty common. But the thinking has changed because some evidence suggests it might actually do more harm than good in these specific situations. Okay, remember how we said over 90% of patients have normal or high blood pressure? Well, what about the other 10%? This is where things get really, really tricky. Managing a patient who has AHF and low blood pressure, we're talking less than 85 millimeters of mercury, is a massive challenge because the go-to treatments, like diuretics, could actually make their blood pressure drop even further. When a patient is in that dangerous low blood pressure state, it's a condition called cardiogenic shock. Doctors have to bring out the heavy hitters. They escalate the level of support. They might start with drugs called inotropes, which basically tell the heart muscle to squeeze harder. If that's still not enough, they move on to vasopressors, which are designed to bring that dangerously low blood pressure back up. And in the most extreme cases, they might even need to use mechanical pumps to temporarily do the heart's job for it. And that really brings us full circle. We've seen that AHF is this sudden, dangerous crisis, but it's often just the tipping point for other chronic problems, especially as our population gets older. So this leaves us with a really big, important question to think about for the future. How do we get better at not just reacting to the emergency, but at actually preventing the triggers that lead to acute heart failure in the first place?